This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Ilara, Research Fellow. Today we're looking at a fascinating new study from Acta Neurochirurgica, published in 2026, titled 3D Digital Exoscope is Safe Tool in the Surgery of Olfactory Groove Meningiomas.
This is a timely paper, Ilara. We've seen the rapid integration of digital 3D exoscopes as an alternative to the traditional operating microscope, which has been our gold standard for 50 years. But specifically looking at olfactory groove meningiomas, or OGMs, presents a unique challenge because of their location.
Exactly. The study comes out of the Helsinki University Hospital and focuses on the transition period between using the microscope and the exoscope. As we know, OGMs account for about 8 to 13% of all intracranial meningiomas. Because they're tucked away in the anterior cranial fossa, they often reach a considerable size before the patient presents with anosmia or neuropsychological impairment.
Right. And from a technical standpoint, the difficulty with OGMs is that anterior skull-base trajectory. It often requires heavy tilting of the magnification device to see the most anterior reaches of the tumor. That's where the authors, Topala and colleagues, hypothesized the exoscope might actually offer a specific advantage.
Let's look at the study design. This was a retrospective cohort study of 22 consecutive adult patients operated on by a single senior neurosurgeon, Dr. Martin Lehecka, between 2016 and 2024.
That single surgeon aspect is important for a study like this because it minimizes the variable of surgical skill or preference during the transition from the microscope to the exoscope.
Definitely. They had 13 patients in the microscope group and 9 in the exoscope group. The transition happened gradually between 2018 and 2022. By 2020, once the department purchased their first exoscope, almost every case was done exoscopically.
What were the baseline characteristics? Because if the exoscope group had easier cases, the safety conclusion might be biased.
It was actually the opposite. The patients in the exoscope group had significantly larger tumors. We're talking a median volume of 61 cubic centimeters compared to only 17 cubic centimeters in the microscope group.
That's a massive difference. 61 cc is a very large OGM.
It is. And predictably, the exoscope group was more symptomatic preoperatively. About 33% of them had a modified Rankin scale, or MRS, of 3 or higher, meaning they required help with daily activities, compared to only 8% in the microscope group.
So the exoscope was being used on larger, more symptomatic tumors. Now let's talk about the surgical technique they used.
The primary objective was gross total resection, Simpson grade 1 or 2, while attempting to preserve the olfactory nerves when possible. For every single case in the series, they used a unilateral frontotemporal approach.
That's a standard workhorse approach for these. Now, when we look at the results, did the exoscope hold up in terms of resection rates?
It did. Gross total or near total resection was achieved in 100% of the patients in both groups. Despite the exoscope group having those larger tumors, the surgical outcomes remained consistent.
What about the time in the OR? One of the common criticisms of new tech is that it slows things down.
The exoscopic surgeries did take longer, a median of 165 minutes versus 121 minutes for the microscope. However, the authors attribute this mainly to the larger tumor sizes rather than just the tool itself.
That makes sense. More volume generally equals more debulking time. But let's get into the safety aspect. Any major differences in complications?
Very similar. There was one severe complication in each group. In the microscope group, one patient had a postoperative hematoma. In the exoscope group, one patient suffered blindness in the ipsilateral eye.
And the functional outcomes?
At the 3-month follow-up, 89% of the exoscope patients and 92% of the microscope patients were independent, with an MRS of 0 to 2. So clinically, the transition didn't compromise patient safety or recovery.
Now, Ilara, let's dive into the most interesting part of this paper for the practicing surgeons and residents listening, the intraoperative dynamics. The study actually quantified how the surgeons moved the equipment.
This was the deep dive I found most fascinating. They reviewed surgical videos and found a distinct difference in how the two tools are used. Microscope-assisted surgeries required significantly more horizontal adjustments, a median of 251 adjustments compared to only 103 with the exoscope.
That's a huge discrepancy. Why do you think that is?
Well, when you're using a microscope, you're often locked into the eyepieces. To change your view, you frequently have to shift the entire base or the head of the microscope horizontally to maintain your ergonomic position.
Exactly. And what did they find regarding the tilting movements?
That's where the exoscope took the lead. Tilting movements were more frequent with the exoscope, median of 122 versus 76 with the microscope. The authors conclude that the wider range of angular movement of the camera head is a major advantage, especially at the anterior skull base.
This is the crux of the argument for the exoscope in OGM surgery. When you're working along the floor of the anterior fossa, the reach of the instrument is limited by the physical bulk of a microscope hitting the patient's head or the surgeon's own neck comfort. The exoscope camera is smaller and more mobile.
And because the surgeon is looking at a 3D monitor rather than through eyepieces, they can tilt the camera to extreme angles while still keeping their head up and their spine neutral. The paper emphasizes that the exoscope-assisted surgeries relied more on these tilting movements to get the necessary line of sight into the anterior-most corners of the olfactory groove.
It's an interesting shift in ergonomics. Instead of moving the whole apparatus horizontally to find a window, you're pivoting the camera head.
Right. The authors mention that the exoscope is a safe tool, even when operating on these very large tumors. Their hypothesis of non-inferiority was supported, and they suggest that the exoscope might actually be the more practical choice for this specific anatomy because of that angular flexibility.
Did they mention any specific limitations or learning curves?
They acknowledge the retrospective nature and the small sample size. 22 patients is a start, but will need larger multi-center trials to confirm. They also noted that the study was conducted during a transition period, so there's always an element of the surgeon getting up to speed with the foot pedals and the digital interface.
But despite that transition, they still hit Simpson 1 or 2 in every case. That says a lot about the tool's reliability.
It really does. To summarize for our listeners, for OGMs, the exoscope allowed for equivalent resection rates and clinical outcomes compared to the microscope, despite the exoscope group having tumors that were nearly 4 times larger in median volume.
And the key takeaway for residents, pay attention to how you're moving your magnification. If you're using an exoscope, leverage that tilt. If you're struggling with the anterior-most attachment of an OGM, the exoscope might give you that extra few degrees of visibility that a bulky microscope would make difficult.
Well put, Dr. Aris. It seems the digital transition in the neurosurgery OR is not just about having a fancy screen. It's about changing the very dynamics of how we access the skull base.
Definitely. That's all the time we have for today. Thank you, Alara, for breaking down this study.
My pleasure.
And to our listeners, keep an eye on the Acta Neurochirurgica for more on these digital platforms. We'll see you next time on the Neurosurgery Hub podcast.